Well, good evening, everyone, and welcome to tonight's episode of the wildly popular non-Netflix Oak Seminar Series, which is sponsored by the Discipline of Periodontics, University of Toronto. I am your host this evening. My name is Douglas DePorter, and I've been at the Faculty of Dentistry, University of Toronto, forever. And I'm still there. Please turn off your audio connections because we don't want the speaker to be distracted. As usual, we'll have three of our current periodontic residents monitoring your questions, which should be submitted online and will be addressed by Dr. Simon at the end of the presentation. The residents will be Boris Galvez, Brian No, and Halle Javidnia, along with the director of our graduate program in periodontics, Dr. Vanessa Mendez. Moving on then, tonight's speaker is Dr. Ziv Simon, who's a periodontist practicing in Beverly Hills. I just found out for almost 20 years. He graduated from the dental faculty at Tel Aviv University, and then he lucky for us, he came to the U of T and participated in our periodontic program. I had the pleasure of being his master's research supervisor, and it was a pleasure indeed. And we kept in touch over the years. Ziv Simon is a diplomat of the American Board of Periodontology. He's a fellow of the Royal College of Dentists of Canada, and he teaches regularly at the University of Southern California in Los Angeles. He's the creator of the highly popular online education program called Surgical Master. And if you don't know it, you should check it out. This is a global teaching program which is meant to coach dentists in how to excel in oral and periodontal surgery, and in doing so, to enjoy their lives and their practices. His presentation tonight is entitled New Strategies and Tactics for Aesthetic Zone Implants, which of course is a very topical subject. We're now expected to be able to produce implant prosthodontics which is indistinguishable from natural teeth. I'll always remember the first time I met Ziv when he presented to my office at U of T to ask if I'd be willing to supervise his master's research project. He was wearing a very smart suit and tie at the time and carrying a Louis Vuitton briefcase, and I thought, this is a young man on the way up. Some good things are going to happen here. And it's true. After graduating from our program, he went directly to Beverly Hills, became a practitioner of considerable success, not only in his practice, but also in his aspirations as a teacher with his online program, the Surgical Master. He has a serious passion for education, both for himself and for others. And as a result of his online presentations, he's been invited to many countries to speak, all the way from Austria to Australia, with Japan and Malaysia in between. Indeed, some of these dentists may be with us tonight, who knows? Since this is a worldwide platform, and remarkably, there are people from recently over 25 countries, I think, attending these seminars. So dear colleagues, it gives me considerable happiness and pride to introduce to you Dr. Ziv Simon. Enjoy.
Thank you, Dr. DePorter. I appreciate this, such a nice introduction, and I can't believe it's been 20 years since I stepped into your office. I still have the Louis Vuitton bag, but actually my wife uses it now, so I'm no longer in use, but being at the University of Toronto for so many years, I went back and I looked at some of the photos, and to be honest, I choked up looking at friends, my co-residents, Jennifer, Irit, Alex, and year before me, after me. They were just great times and carefree. And here is my first implant surgery, where I'm being instructed by Dr. Avi Chalamet, who was a year ahead of me and became a very good friend of mine. And just great times, education-wise, lifestyle, friendship. And I think that part of my life I will never forget. And Doug, you're somewhere up there among my mentors and my friends. So tonight, I'll talk to you about some of the strategies and tactics I've been using for the past 6 to 7 years when it comes to the very challenging aesthetic zone. And before we talk about socket shielding and pedicle grafts, I wanted to spend just a couple of minutes talking about practicing at the time of the pandemic. And as you can tell, I'm wearing a mask because our practice is a fully masked environment. There's no 1 second where you can walk around, myself, the doctor, the staff, and the patients, unless they're getting treated without a mask. So believe me, it's me. I have a name tag. And it's been a challenge for the past year to live through this pandemic, to be a practicing professional, no matter where you practice. Every person was affected, and I don't have any intentions to talk about the pandemic protocols, but just give 2 cents of advice when it comes to business practice at the time of the pandemic. Well, business is not as usual, as you can tell if you're practicing, and things are not easy, but it is possible to be successful, and it is possible to be even more profitable at the time of a pandemic, as long as there are a couple of conditions that are fulfilled. And this is a book that I strongly recommend to read. This is my Bible. I've read it multiple times, and I go by it, The Road Less Stupid, on how to avoid the dumb mistakes that sabotage growth, profits, and business success. And I don't get any percentage of book sales at all. It's by Keith Cunningham. And I promise you, you will not regret, and you will not be the same business person after reading the book or the other teachings or the other teachings of Mr. Keith Cunningham. So you can be successful at the time of the pandemic if you cut expenses and cut them hard with no mercy. Get ahead of the curve ASAP. You need to trim the fat. You need to trim some of the muscle. Don't touch the bone. But that's the key to success when this type of crisis hits, and not just at the beginning a year ago, but constantly finding ways as a private practice practitioner, as a business person. I'd like to practice periodontics at the highest level for the rest of my life, meaning as long as I can. And in order to do so, I need to be a good businessman. And I need to make sure that my practice continues to thrive even when a crisis hits us like a pandemic. So cut your expenses. Hardest part to cut is obviously your payroll. And that leads us to the second very important advice, and that is we must focus on communication. We must communicate clearly, candidly with everybody, with our employees, and explain to them why we must take certain measures to protect our business, to protect our practice, to make sure that there's a thriving work environment that they can come back to when this pandemic ends or when conditions improve. We must talk to our landlords, our bankers, our lenders. We must take care of our different liabilities. We all have different liabilities in life, in our personal and our business life. We need to keep an open line of communication with everybody because everybody is worried. Everybody's looking to us. Will they fulfill their promise to pay on their loans? Will they default? Keep an open line of communication, keeps everybody at ease, and find ways to work through this pandemic naturally with your family. Cut your expenses and communicate about what is happening. And as a periodontist, in a practice that is fully referral based, speak to your referring dentists and educate them about how they can thrive at the time of the pandemic, how they can keep their practices going and naturally with your patients. So one of the things that helped tremendously in my practice is education that I'm anyhow passionate about, as Dr. DePorter mentioned, but even more so, creating education programs for our referring doctors, for our patients, educating them about the pandemic, how to protect themselves. That paid tremendous dividends in my practice. And pretty much to sum it up, we look at this pandemic, at the business handling of the pandemic, almost like an emergency room approach. We have a patient in critical condition, and we must stabilize the patient and make sure they survive, and then we deal with the rest. That's really what has been going on for the past year. And like in an emergency room, we must have extreme focus. We need to constantly monitor the vital signs, our KPIs, our production, our expenses. We need to have massive flexibility in responding to this crisis and other crises as they occur. And we need to do everything in speed of action and interaction, like in an ER, full seriousness. And that's how you can thrive. So your single biggest mistake in this crisis is to freeze and have no plan, no life jacket, just write it out. It's not going to work. You want your practice to be successful, cut the expenses and communicate. Okay. So going to talk a little bit about the aesthetic zone implants. And the aesthetic zone is naturally very challenging. I'm practicing in a very high liability country and environment, Beverly Hills, high aesthetic demands. And there's really no forgiveness when it comes to aesthetic rehabilitation, especially when it's only one central incisor implant, especially with our high smile line patients. So sometimes we make mistakes, surgical mistakes in positioning the implant too buccal, too mesial, too distal, and that will have its implications. Sometimes we can add insult to injury and make additional restorative errors, like over-contouring a restoration, not making it cleansable, already starting from a compromised position that can create an infection. So looking at those challenges, I always wondered, what are the best predictors for success in the aesthetic zone? And I came to the conclusion quite rapidly that it's the adjacent teeth, and specifically the amount of attachment, the level of attachment on the adjacent teeth. And the more that attachment is intact, the better the results would be. And the more it's compromised, especially the interproximal bone and tissue, the less favorable the aesthetic result of the implant. But also, naturally, the buccal plate. And that's been in discussion since I was a dental student and then a resident. What can be done to preserve this structure that is most commonly less than 1 millimeter in thickness? What can we do to preserve it so we don't have gingival recession or a ridge collapse? Well, we're dealing with the alveolar bone, which is functional bone. And when the tooth is lost, then very often the bone is lost and the tissue is lost. What's more resistant is the alveolar bone. And what comes to our rescue usually is the palatal bone. And the palatal bone, technically, histologically, anatomically, is considered alveolar bone, but it really behaves like basal bone. It's more resistant to resorption. And that really saves us for all those cases where you have a blown out buccal plate. And the question that we're all dealing with on a daily basis in practice is, can we preserve the buccal plate? And I want to share with you a few clinical situations, very common in your practice, in the university, anywhere around the world, anywhere I communicate and educate and mentor dentists and specialists, that these scenarios come back. For example, when a tooth is non-restorable and we have thick tissue, thick bone, a wide zone of attaching keratinized tissue, and we utilize an atraumatic extraction technique. This is the Benex extraction system. I'll share the exact technique in a couple of cases. And using the fully guided implant placement approach, planning and placement, which is how I place implant exclusively in my office for every case. And when we get the implant in the right position and proper tissue quality and quantity, then the result can be quite pleasing. And this is the before and this is the after. Although we lost some of the interproximal tissue around the right central incisor and also the distal tissue to some extent, I would love to have this result every time if I could guarantee it, but unfortunately, such things cannot be guaranteed. So we learn to accept these types of acceptable results, aesthetic results, and for most patients, they're quite pleasing, and I'm also pleased as a clinician. However, my focus, and the longer I practice, and it's been now over 20 years, I focus on communicating with the patient prior to the treatment. And I hit 4 very important points, and I communicate in the patient's own language, in layperson's terms. And I say the following: when a tooth is lost, the bone starts to resorb. The bone is lost. We can minimize it, but we cannot prevent it. If it happens, the tooth will look longer, and sometimes the tissue in between the teeth shrinks. That's the loss of papilla. And I make sure that I review those points, and I'm not scared to lose a case, and I'm not scared if a patient starts to cry, which happens every once in a while. But we need to be very open and communicate candidly and openly with our patients. Extremely important. So I'll go over a couple of scenarios. For example, an immediate case. Can an immediate placement approach, immediate loading approach prevent the loss? At least we used to think so. I don't think so. That's common knowledge anymore. But we can take a patient from planning process, extracting and replacing a tooth that is hopeless with root resorption. There's a history of trauma. Extracting the tooth as atraumatically as possible using periotomes, Benex extraction kit, making sure that we have the buccal bone and the soft tissue. Again, as best as possible, every extraction is pretty traumatic. We're removing a structure that has been there for decades. And following the guided protocol, placing the implant in the proper restorative position with the proper 3D positioning, and even the timing can be figured out in the guided approach. Grafting the small gap between the implant, and at this point, I don't measure the gap. If there's a gap that can accommodate bone particles, I graft the gap, and the implant can be loaded. And it was loaded immediately, and after 2 to 3 months, it was then restored, and quite a pleasing result for this patient. And some of these catastrophes in the aesthetic zone, they're not fatal. They're not fatal, and we can get great results. But also, the success is not always final. So I strongly encourage you to always look at your cases, not 6 months down the road, but 5 to 6 years down the road, and see how they look like. They're not going to look the same. And for this particular patient, a few years later, we can start seeing the graying showing through the gingiva. Not terrible. Patient is not concerned at the moment, but it's something that we need to look at, and be aware of. Even if the protocols were proper and were followed to the T, we can still have these types of long-term problems. For cases of trauma, when the tissue is very thin, well, there's no bone to begin with. And for these types of situations, a pre-placement grafting procedure is needed. And you can see that there's a large defect, buccal defect. The height is reasonable. This was a trauma for an actress, young actress, during shooting of a movie, and she got injured, lost the tooth, lost the buccal plate, and she needed to have a guided bone regeneration procedure with membranes, and that can regain some of the bone and even perhaps some of the tissue that was lost in the process. And this case can be planned for a guided implant placement. Again, using the guided protocol, I use it exclusively. Now that the technology is affordable and available and predictable, implants can be placed in the proper restorative position all the way to their final position. So getting the tissue to a certain proper level and restoring it properly after a few months can make our patients very happy and very relieved. But I'd like to take credit for this case, but it's really the credit is to the adjacent teeth. The adjacent teeth have proper attachment. They have good interproximal tissue and bone. The patient is young and healthy, and these are the best circumstances. By the way, this is not a typical case in my practice. This is a case that turned out extremely well. Not all of my cases are like that. But we need to follow up this patient for a couple of years. And after a year or two, you may see that your success is not final. You may start seeing some grayness, although the bone was grafted, although the implant was more palatal in a screw axis position. We may start seeing bone loss, bone resorption, and that can only be monitored and hopefully never needed to be treated. But we see this quite commonly. So the question is it the extraction technique that I'm using? Is it the grafting procedure, the graft material? It's hard to tell. I've tried all the different graft materials on the market. And for this case, you can see the horizontal fracture that is subosseous. Okay. By the way, a protocol that I've started in my practice 20 years ago is called the Timeout Protocol, and that's where I mark an X on the tooth to be extracted and follow a certain sheet that is called the Timeout Protocol, where I review with my patient and my team the exact procedure. And part of this process includes the actual words we are saying to one another and confirming which tooth needs to be extracted. It's just as easy to extract the wrong tooth, and I'm happy to share this form with you. So this tooth was already broken, horizontally fractured, subosseous. There are a couple of ways to remove this tooth. My preference is to use the Benex extraction kit. I strongly recommend every specialist, periodontist, anybody who is involved with these types of extraction to invest in it. It pays dividends, and I use it probably not more than 2 to 3 times a month, but it's certainly worth it. Basically what I'm doing, I'm anchoring an extraction screw into the residual root. Into the extraction screw, I connect a chain or a cable that connects to a pulley system. And you can see it right here. The white part is the bumper laying against the teeth. And then using the knob and rotating it clockwise, that pulls on the cable, that pulls on the extraction screw that is connected to the tooth. And therefore, the extraction is very simplified naturally for more or less straight teeth in usually single-rooted tooth, although it can also work on upper premolars. And observing the socket, you will have the most ideal socket. In this case, I decided to use a dentin graft. So I use the actual root itself. I scale and root plane the PDL, although that's not 100% necessary. It goes through a processing, that removes the organic material. I release the extraction screw from the root tip and place it in a machine. There are 1 or 2 machines on the market. I think there are 2 companies that use it. I use Cometa Bio from Israel. Again, no commercial affiliation. I'm just a customer. And this machine will pulverize the root tip into particulate graft. And then it goes through a process of removing the organic material. So we're left with the mostly dentin. A tooth is made out of mostly a dentin material in a particular particle size. And when we pulverize the solid, we usually double the volume. So we get quite a bit of material. You can also repeat the same process to the enamel, but the dentin is actually more important and has more growth factors and a lot of bulk. And the way this graft works, it integrates with the bone around it. It doesn't get replaced. So gets replaced very, very slowly. So I use it like a conventional graft. We have a full wall extraction socket, ideal socket, an extraction, and then on top, a PRF plug with a few X sutures. I believe they're gut 5.0, just to stabilize it. Very simple, removable appliance, and very, very quick healing. And that's something that I've seen, assuming the patient has good healing potential, I've seen more rapid healing and a great site for an implant in a shorter period of time. Actually, I don't like to wait too long, otherwise the bone becomes too hard, and bone that is too hard, as you know, is not ideal for implants. We want to have the 2 and 3, type 2 and type 3 bone for proper initial stability and proper vascularity. And then through the guided process, again, fully guided placing the implant, I chose the flapless approach because I had enough attaching keratinized tissue. Placed the implant to the final position. I planned them 3.5 millimeters subgingival, assuming the gingiva is in the right position, which it is right now. And this is the final result after 3 to 4 months. Again, I would love to have this type of result every time with proper tissue, although the contour of the tissue is not ideal. You can tell it's a little bit concave. I think there could have been a little bit more due diligence with working on a provisional restoration and creating a much better emergence profile, or maybe I should have used a flapped approach and create more buccal tissue. But interproximally and buccally, height level, tissue level wise, I'm quite pleased, and I would take this result anytime. And again, this is not a typical case in my practice. I wish it was. Okay. By the way, I did a frenectomy at the same time of the implant placement. You can see some scarring on the right photograph to eliminate any pull on the potential gingival margin. So with all the techniques, even if protocols are followed, and I'm having a good day doing these types of procedures and things are going my way, we're not always getting the ideal soft tissue architecture. And these cases are very common. I mean, probably a couple of times a week, we'll have a patient coming in with a fractured, non-restorable central incisor with a history of trauma from before, root canals that have been done, crowns, restorations, done and redone. And at some point, the tooth is simply not restorable. And starting around 7 years ago, I was exposed to the socket shielding technique, mostly online and reading the scientific literature that was available back then. And thinking to myself, when I'm extracting a central incisor or any tooth, but let's focus on the upper centrals, that's the image I have in my mind. The thin buccal plate, the slightly thicker palatal plate, the buccal position. And wouldn't it be nice to preserve the alveolar bone by retaining some of the root. And that's in essence the principle of socket shielding. You will have, I noticed, Howie Gluckman from South Africa. He's, in my opinion, the authority on socket shielding, or one of the authorities. And I learned quite a bit from him. And a lot of it was through trial and error, which was exciting, nerve-wracking, but ultimately proved to be a good technique to utilize in my office. And I'm happy to answer some questions. So the idea is to leave some of the buccal aspect of the root attached to the buccal plate, extract everything else, the coronal aspect and the palatal aspect of the root. So the bone and tissue are going to remain unchanged. And then place the implant either immediately or in a delayed fashion. I personally prefer to place delayed implants more than immediate implants, and place it slightly palatal in the proper restorative position. And that's, in essence, is the socket shield technique. A few articles. The first one was by Hertzler and Zur, our German surgeons that are well known for their soft tissue handling and what we call the pink book. And they describe this technique. There are more articles by Gluckman and by Salama and other articles that you can look up, and look at them as technique articles, although there are a couple of histology articles. But learn the technique. The technique is very important because it is a technique-sensitive procedure, and it involves 3 steps. I wish I could say 3 simple steps, but it's just 3 steps. Step number 1 is our mesiodistal sectioning or split. Step number 2 is removal of the palatal component of the root. And step number 3 is adjustment of the shield. And I'll let you know the criteria of how we need to adjust it. So once we created those 3 steps, we would like to have the shield more or less as 1 millimeter in thickness. We want it to be at bone level and more or less a 45-degree internal bevel to allow for some restorative freedom and flexibility. And so your restoration is not pushing against the shield. So these 3 points are very important. Initially, when I started, I did all my cases as delayed placement. I wanted to make sure that I'm getting adequate bone. I also wanted to visualize the shield on a CT scan prior to placement and basically see what I'm doing and grade myself. It's not always something that you want to look at, but it's actually quite interesting to see those shields working out, even if you're just getting started. Okay, so here's the shield was created. A routine bone grafting procedure with allograft material, a PRF plug, 1 or 2 X sutures, keep it simple, and let it heal. And for most cases, very, very nice soft tissue aesthetics. Here's the cross-section, the buccopalatal cross-section. You can visualize part of the shield. By the way, this was one of my first cases. Not too bad, but you can see that the shield is not continuous. This is where my burr probably went more in a buccal direction in an angle and ruined some of the shield. But the critical part of the shield is the coronal part or the incisal part. You can see it continuing here, the apical part. And you'll also identify it on the 3D rendering. Okay, again, it's just a change of kind of a mindset change or a shift towards leaving some of the roots there. And we correlate the 3D rendering and the cross-section. We plant the implant in the proper restorative position for screw access. I don't like to engage the shield. I'm concerned that engaging the shield can mobilize it and disrupt the attachment to the buccal, which is the whole point, and ruin the whole plan. So I keep it at least a millimeter away if I can. And again, following the guided protocols for fully guided placement. Here's the final placement of the implant, the soft tissue architecture. And the arrow is pointing to part of the shield that I'd like to think I left it intentionally to support the papilla, but it's hard to create this intention with a closed approach, which is preferred. I try not to reflect the flap when I do my socket shields, although sometimes you need to. So that creates a really nice corresponding soft tissue. So what are the requirements for socket shielding? Number one, no mobility. So periodontally involved teeth are not great candidates for this procedure. I strongly recommend you get a CT scan prior to rule out periapical infections that are not visible on conventional radiographs. And also, more than that, is to plan your socket shield procedure to see what is the angulation of the root inside the alveolus, so you can hold this CT scan in front of your eyes while you do the procedure, and you can adjust your angulation of your burrs. You must use very long burrs. There are now socket shield kits. I think there are about 5 on the market. You can just look them up, and they're pretty much the same. They're just long surgical drills that walk you through the different aspects of the socket shield procedure, from the splitting to the preparation of the shield and the adjustment. And very important is, in order to execute a socket shield procedure, the buccal plate needs to be there. So if you have a fully blown out buccal plate, that's not a case for socket shielding. Unfortunately, that's not going to work out. And it's better to find out ahead of time rather than creating the shield and the thing is just flopping in the wind. Not a great thing. So be prepared using a scan and the proper instrumentation. Is it okay to engage the shield? I personally don't. I keep the implant about 1 millimeter away from the shield. And we can do this very well in our guided protocol. But the histology shows, and I think this was an animal study, where the implant engages the actual dentin in the surgery. But if you look at it microscopically, you see the histology, and we see this with implants as well. As they're being placed in bone, there's a very small microscopic gap around the threads that allows the bone to grow underneath. So bottom line, it's possible to do. My preference is not, and it would be great to refer to this question again when Howie Gluckman is speaking for you guys, and get his opinion. He certainly has done more, knows more about that than me. Should we do it immediate or delayed? I don't think it affects the success. As we know, with in general consensus, immediate or delayed placement success rates are no different. There are more challenges with immediate placement. This is an immediate case. By the way, this patient was advised that she has delayed eruption patterns, and we discussed aesthetic crown lengthening prior to the placement. She was quite happy with the way her teeth looked like, but one of them was non-restorable. So taking a CT scan and looking at the cross-section, planning the implant in the proper depth. And this is the procedure itself, the mesiodistal split or mesiodistal sectioning, removal of the palatal component, and then adjusting the socket shield to be at bone level and the 45-degree angle, and then placing the implant fully guided. Now, I decided to place it a little bit deeper, just in case she changes her mind about aesthetic crown lengthening. I hope I buried it enough, because now she's complaining a little bit about her excessive gingival display. So here's our gap between the shield and the platform of the implant and the body of the implant. We graft the gap. This one was grafted with bovine material. I think it was bioos. And healing abutment. And you can see the contour, which is not surprising, is the same contour as it was before the tooth was extracted. Now it's restored. And you can see, there's some benefit in changing the gingival margin, create better teeth proportions in general. And then that may be next, and I hope the implant is deep enough so we can actually do that. Any problems, any complications? You bet. Tons of new complications and new problems that you haven't seen before, haven't experienced before, because they're not very well reported, and you'll pave your own way in dealing with them. Just be prepared, because it's a little bit technique sensitive, not simple to do, not for me at least. And there could be some complications, and I wanted to share 3 with you. So where will you have these types of complications? You'll have them in each aspect of the procedure, in the mesiodistal split, the palatal root removal, and the shield adjustment. All of them can bear a few complications, and the list is pretty long. These are, to me, not biologic complications. They're more technical, because you're not seeing that well. And you're using these burrs based on a scan, based on your manual dexterity, and we're not robots. So it's not always easy. So I wanted to share with you a few cases. This is one of them. This is a patient that had root resorption and had some orthodontics, and tooth was pushed almost outside the bony envelope, but you can see a very thin layer of the buccal plate. And we may have some, I guess, root perforation through the buccal plate, but the coronal aspect is actually there. And we know that once this tooth is extracted, this is going to collapse pretty rapidly, and we can probably get a reasonable result, but we would like to preserve it. So I tried to do a socket shield, and this patient's bone density was very similar to the tooth density. And I created a dehiscence. It was a surgical error, more towards the distal part of the tooth. I reflected a small flap to visualize it, visualize the damage. And this is a type of defect that can be repaired and addressed. But the flap reflection was actually a blessing in disguise for me looking at that, because then I could go in there and I could do a little apical surgery, remove the root tip that was sticking through the buccal plate, and preserve the very thin layer of bone that was there. We probably have too much volume, but too much is not necessarily a bad thing. So it was repaired using a resorbable membrane, and overlaying it, you can see a PRF membrane that overlays the buccal aspect, and the occlusal surface underneath somewhere here. There's a PRF plug peeking through, and this surgical site is closed up with just gut sutures, combination of 4 and 5/0, and letting it heal for a few months, at least 3 months, before taking a CT scan, and then visualizing the socket shield on the buccal, not to the full extent because the root tip was removed during the procedure, the pretty impressive volume, the 3D rendering on the left. And this implant can be placed now in a fully guided approach. I usually prefer to use somewhat of a flared healing abutment. The dentist actually intentionally asked me to use a non-flared. I would have profiled the bone and would have put a longer and flared one, but the dentist did not want that. There was a bonded restoration, and as you wish, no problem. It was easy to do. Okay, so here's the volume of the ridge prior to the restoration. Now, one of the criteria of socket shielding is that the shield must be at bone level. And here's another patient that came in with root resorption. You can see the pink appearance of the root due to severe resorption, history of trauma, no root canal treatment, no endodontic treatment. You can see this beautiful long papilla in between those central incisors. Will I be able to preserve it? Probably not. Probably not. These long and thin papillae, they dissolve quite a bit, but we can see the hopeless condition of the tooth. No pain, no discomfort, but the tooth needs to be removed. It's severely resorbed, And the recommendation is to socket shield. You can see the thin layer of bone on the buccal, socket shield it, graft. So the first thing that I did, I removed the contacts, make sure I don't damage the adjacent teeth. Then I sectioned off the coronal aspect and then created my shield. But then I thought to myself, what if I leave the socket shield, even with part of the enamel, at the soft tissue? Isn't it better? I kind of went against what I learned from people that have done this before me. Isn't it better? Then we'll get the long junctional epithelium in addition to the PDL, and I'll just get a better result. So I grafted it. I left it at tissue level. You can see some of the enamel is sticking out. An allograft material. I think this was just a collagen plug right on top, a few X sutures, but I made the wrong decision. The wound refused to heal after a week. You can see the non-vascular bone graft right underneath. And we know, just looking at it, we know that this bone graft is not working at all. And we need to remove it as soon as possible. So all I did with a little bit of local anesthesia, I removed the bone graft material, curetted it out, and trimmed down the shield to more or less bone level to allow for soft tissue closure. And indeed, as we know, soft tissues are going to close. We're going to lose some height, but we're going to be able to get not primary closure. We will be able to get secondary indentation healing. And then going back, when I wanted to place the implant, naturally the bone graft did not heal well. And this was more of a scenario of a immediate placement, more or less. The socket was only partially healed. Again, the guided approach, place the implant, socket shield is at the bone level, a gap to graft, and then closure around the healing abutment, letting it heal. And this is more or less the healing after it was restored. So we didn't get the exact contour of the tooth like before, but the height was there. The papilla did not make it. We didn't get the tip of the papilla to be where it was before, but the gingival margin was actually more or less the same shape of the tooth. Again, the patient is very happy, but this complication was addressed by removing the bone graft. Another type of complication is when we remove the palatal aspect of the root, it very commonly breaks because we get the initial mesiodistal split slightly too much to the palate because we don't want to damage the shield. So we overcompensate. And sometimes you lose track what is bone, what is tooth, when those fragments start to come out and we take multiple radiographs, but that doesn't help in 3 dimensions. This is a challenging case to begin with, where a crown lengthening was done a long time ago. So we need to at least retain what we have as best as possible. It's a non-restorable central incisor. And I did my best. Here's where the palatal aspect of the root broke, and I really couldn't tell what's root and what's bone. Bone was extremely dense. So I did the best that I could, grafted it, used a PRF plug, and planned the implant. And so far it looks pretty good in terms of the socket shield that I created. But if you look at it at the more incisal view, you can see that I left the palatal aspect of the tooth itself. Notice that with all the processing and not being able to see or feel, it was left. Let's call it a socket shield ring or something like that. It was not done intentionally. And then I needed to think, what would be the best option for this patient? Should I go back in there with a separate procedure, remove the palatal aspect and only graft again? And I decided to place the implant as is. And I didn't feel that biologically it's any different than the socket shield, but it's certainly something that can happen. Last problem that I noted in doing many of those socket shield procedures is shield loosening. Once it loosens, it causes an infection. And if it loosens later on when the tooth is already restored, and the implant integrated, then sometimes it requires removal of the loose shield without compromising the implant, and naturally we'll lose some of the tissue. But in this case, once I placed the implant, socket shield was already done. You can see the image on the left when the implant was placed, and only 3 weeks later, you see massive bone loss. And clinically, the shield loosened up, and when it loosened up, it needed to be removed. And unfortunately, it needed to be removed with the actual implant with a tremendous defect and an inability to redo that. So not every case is a happy ending. And by the way, this is also not a typical case in my practice, not the superiorly great aesthetic results, and not these catastrophes. My cases are in between. Lastly, I wanted you to consider the socket shielding as an option. I know there's not a whole lot of scientific evidence, but for all of us practicing and treating patients and seeing that the buccal plate is extremely fragile and cannot always be retained, it's another thing that we can consider. This patient came in with a different problem. It was quite concerning. The tooth was fractured, but the infection was mostly on the palatal aspect. And this is even more concerning than losing the buccal plate. The palatal bone is usually much more resistant and pretty much saves us in terms of the implant placement. But also if we needed to do an augmentation, at least we have the buccal plate to attach or to rebuild towards and attach membranes and screws or block grafts, whatever needs to be done. But when the palatal plate is gone, you can see the amount of denuded root surface, very, very concerning. So I needed to think about, first of all, doing the socket shield to the best of my ability, but also trying to rebuild the palatal aspect of the roots. And you can see the infection here on the palatal aspect. Here's the nasopalatine canal and the large infection. So here's the day of surgery. This was a full zirconia crown. I asked the dentist to remove it because if I have to remove it, it will be about 20 different diamond burrs in just a long time. So that it was removed. Unfortunately, the crown was removed with some of the gingiva. And this looks like some type of hemostatic agent, but a tiny bit damaged. So my thought as the clinician treating this patient is not just the bone, but also the soft tissue. And free grafts don't work very well in my hands. They can work, but not as predictable as pedicle grafts. So beyond the socket shield, for this case, I also decided to use a rotated palatal flap. In brief, how it's done, one of the ways to execute this is a full thickness flap, mostly from the molar all the way to the contralateral central in full thickness, and then starting the split from distal to mesial direction, leaving it attached close to the extraction site so it can be flipped over. And don't try to flip it over too soon because you're using a lot of the bulk. Try to get as close as you can, at least the mesio-palatal line angle of the lateral, in this case, before it's flipped over the ridge. And this is, by the way, the region, almost the area of the rugae where you can get most of the perforations. And they happen in my hands at least 40–50% of all times I get a small perforation, because this is exactly where we change angles with the number 15 blade to allow the flipping. And this is where you can also get a small, tiny bit of sloughing. The key for this to work, in my experience, is to make sure that the rotated palatal flap gets placed underneath the buccal tissue. So you need to use a tunneling instrument. It's not necessarily reflect the flap. Try not to reflect the buccal tissue at all, if you can. But try to tunnel it with tunneling instruments and tuck the pedicle underneath. And then it needs to be stabilized. So just to make sense of the suturing techniques, this suture right in here, which is proline 6.0, is just to keep the tip of the flap underneath the tissue. And the rest are just attaching to it and a few X sutures. It looks like a little bit of a mess, but these pedicle grafts work very well because they are continuously vascularized. They never lose their vascularity. This is a simple retainer with a tooth. It applied a little bit of pressure on the tissue. You can see it here from the occlusal, slightly from the occlusal surface where the pressure was, but the graft itself is vital. Question of time until it's going to turn over and mature. For some reason, I got some thickening of the tissue here on the palate. I'm not sure why. Maybe there was some space creation and the tissue grew in. We get some extra tissue for the future. And the tissue has matured with enough thickness due to the socket shield in combination with the pedicle flap. Again, this is not a typical case in my office. I want to be fully transparent, like in all of my teachings. So certainly an admirable compliment here to the human body that can heal so well. Again, always look at your CT scan. Here's the buccopalatal section. You can visualize the socket shield. You can see that the palatal bone stops somewhere around mid-ridge. This is where it was, so we're not expecting cortical bone, but we can see pretty well-defined ridge, good thickness of the ridge, and this implant is now planned, fully guided. You can see it in the 3D rendering, about 1 millimeter away from the shield, and placed fully flapless. And this is at the time of implant integration check. It's fully integrated and ready for the restorative process. So the verdict on socket shield: use caution, prepare yourself, have the right tools and instruments, a CT scan, have the right patient with the proper consents, communication, and expectations. I don't treat everybody. If I communicate those 4 points I reviewed with you before, and the patient replies and says, well, I don't want that to happen. That's why I came to you. I heard you're the best. And I say very clearly, I'm not the best. This is biology. This is a process where when a tooth is lost, the bone is lost and the soft tissue is lost, and the tooth can look longer, and you can also lose the tissue in between the teeth. And this is what I propose we do to minimize that. So the verdict is thumbs up. I have great results with the socket shield. There's a learning curve of probably about 6 months to a year, and doing more and more. And you can decide for yourself. Thank you so much.
Thank you, Ziv, for that very honest and interesting and talented presentation. And so I think, Ryan, are you now responsible for the questions?
Holly will be asking the first question.
Okay, thank you, Dr. Simon. That was a wonderful presentation. We learned a lot. My name is Holly Javidnia. I'm a third-year perio resident at U of T. And our first question here is, how long does the Dentin pulverization process take? And how long do you wait to re-enter for implant placement when using this material?
Great question. So the actual pulverization or the grinding only takes a few seconds. So it takes about 15 seconds total to break the tooth structure into the mineral, but it takes about 15 minutes for the chemical process that also includes EDTA to remove the organic material that is inside the tooth that we don't want to put back in there. So total, I would say about 15 minutes. And just to add another point, there's also cost for each use of the machine. The actual grinding part is disposable. So that is an additional expense. If you had some type of notion that there's no, we don't need to pay for bone grafts anymore, that's not the case.
Thank you.
Hello, Simon. Thank you very much for the presentation. My name is Ryan. I'm a second-year perio resident. The second question I have for you is, what is the minimum volume of space between the implant and the socket shield to warrant bone graft, or do you try to graft in all cases?
So I personally graft in all cases. I don't look at the minimum gap of less than 1 millimeter where I feel like we don't need to graft. I just don't see the downside. So personally, I graft all cases.
Thank you very much.
Thank you, Dr. Simon. My name is Boris. I'm a first-year resident at U of T. And the next question is, any thoughts on using a 3.3 diameter implant versus a 4.1 millimeter to help prevent buccal bone loss?
Yes, so that's naturally dependent on the tooth that we are replacing. So if you're looking at the aesthetic zone, I personally do place implants that are around that diameter, of the narrow diameter, 3.5, based on the system that I'm using in my practice. And it's certainly an option. However, if you have a wide ridge that can accommodate a regular size platform, while still maintaining at least 2 millimeters of buccal bone thickness, I think that's more advantageous, mostly from a restorative point of view.
Thank you. The next question here, have you ever had a scenario where the coronal part of your shield is infected, and how do you manage it?
Great question. So I did have all sorts of scenarios like that. And if the coronal part is either, well, the tooth itself is not infected, it's the structures around them. So I basically abort the socket shield procedure and I proceed with a conventional bone graft. And it does happen, and it will happen when you attempt that.
Great, thank you. Next question is, do you ever make custom healing abutments chairside for immediate implants in the aesthetic zone?
So personally, I don't. I have several referring doctors that do that. So they either come to my office or the patient goes to their office right after, or the temporary abutment or even the temporary crown is made pre-made prior to the procedure because we use the guided protocols. But I personally don't. I choose not to.
Thank you.
I just don't enjoy doing it, and I never educated myself enough to be able to do that, and I'm not planning to.
Great, thank you. The next question is, for a delayed socket shield approach, how long do you wait?
So for delayed socket shield, I wait just as long as a conventional bone graft. So the minimum is 2 months and up to 6 months, depending on the patient's healing.
All right, and last question I see here. Do you approach an ankylosed tooth differently?
Absolutely. So an ankylosed tooth it's a type of an extraction where we are not mobilizing the different fragments. We basically have to drill the tooth out, and that adds to the level of stress and time and how meticulous you are. And for these cases, I would, obviously like to use magnification and a flap approach. But it's not as clean as I described to you.
Okay, thank you. So those are all the questions. Thanks again for the presentation, Dr. Simon. I would like to hand it back to Dr. DePorter now for a few words.
Okay, well, thank you very much, Ziv. That was most interesting. And obviously, you have become very talented with this rather challenging procedure called the socket shield. Have you ever done any molar socket shields?
Yes, inadvertently.
Ah.
Yeah, seriously. So I had a couple of situations where the molar extraction was challenging. The bone was dense. The tooth fragmented into so many pieces, like it happens every once in a while. And then I felt that for those fragments that are close to the buccal plate, in order for me to rescue them, I might as well leave them. The implant is far away, so it was not intentionally planned, but I've done that. But I don't see, Dr. DePorter, I don't see the value in planning that, because usually for molars, we have, for the most part, we have wide enough ridges.
Right. Okay, thank you very much. And I want to thank everyone for participating this evening. Hopefully you enjoyed the presentation. I'm sure you did. And I just want to point out that we do have these seminars happening every second week until I think the end of June, something like that. The next presentation will be an unusual one because it'll be given by someone in Italy, a young practitioner from the University of Bologna. His name is Ilham Musif, and she will be presenting on the prevention and management of complications in root coverage procedures. Root coverage procedures, of course, being a very common part of a periodontal practice. So I should point out also that the timing will be different. Instead of Monday, we'll be doing a Friday afternoon at 4 p.m. our time, so that the presenter can actually stay awake long enough to give the presentation. And it'll be on Friday, March the 12th at 4 p.m. And I would encourage you to register and participate in this seminar. And having said that, I'll say good night. I'll say thank you.
Sorry, Dr. DePorter. Sorry to interrupt. And Dr. Simon, we actually have like 4 more questions that came in the very last minute.
Okay.
If we can just ask those.
These are the best ones.
So the first one here, let's see. It says comparing the socket shield to a CTG at time of placement, do you see an advantage to the socket shield in the medium to long term to justify the increase in technical and biological complications?
Great question. That sounds like a question that Dr. Vinay Bid would ask, but yeah, I think, well, I rarely use a free connective tissue graft at the time of implant placement, so I don't have the direct comparison, but I believe the advantage of this technique, once you overcame the learning curve in those complications and you gain some confidence and the clarity on how to do it, I feel it's superior to that. I feel so.
Great, thanks. The next one is, what do you think regarding the long-term success of the PAT technique, given that it's around 10 years old?
Wonderful question. I don't know the answer to that. I'm very transparent in speaking to my patients, and the one thing that I have in mind is the continuous maxillary growth that would probably include the shield itself while the implant is ankylosed. So I've been using this technique for 6 or 7 years, and I don't have enough long-term follow-up to know, but I think that's something that the future will tell. I've seen some issues with shield loosening. that need to be managed locally. But I think that's a concern. That is a concern. So one way to look at it is to consider the age of the patient as well, and also the pros and the cons of the socket shield, because it does have a technique sensitivity.
Thanks. So actually, relating to that, what are the contraindications to using socket shields?
So to begin with, if the tooth is mobile, if the bone, the buccal plate is not there to begin with, if it's not there, there's nothing to shield. We're shielding nothing. So we need to proceed. That's pretty much it. I mean, if you don't have the proper instrumentation or the instruments with the long enough burrs, you're not well equipped, you don't have a CT scan, I look at it as a contraindication. It's a relative contraindication because it can be resolved by getting the right tools and getting a CT scan. I feel that the more you're prepared for this procedure, it's like preparing for battle. You prep. You got all your ammunition, you got your helmet, and you got a little bit of water, and you got some courage too when you go to battle. But you're prepared. You did your due diligence. I think that's important. I think that's probably important for any procedure that you are tackling. Don't just go in there blindly and be like a cowboy. It just, in the long term, it's going to be against you. So I hope I answered the question. I forgot what the question was. I think I did.
Yes, that was good. It's just about the contraindications.
Excellent, exactly. Thank you.
Okay, so I think that's all the questions. Thank you again for the wonderful presentation.
Thank you. And I wanted to, before we say goodbye, I wanted to say hi to, I see some of my, I think Irit Choval is here. And I saw my instructor, Dana Levy, who's been in touch with me for a long time, and Vinay. And I've seen a couple more familiar names. Hey, U of T was great, and great times, great memories. Dr. DePorter, same to you and the whole team. Probably one of the best times of my life. And I'm not just saying that. Education-wise, spirit-wise, teamwork, academic achievement. And I just, I wish I could come back and see more of you guys. Just life is too busy.
And successfully, the Louis Vuitton briefcase was recycled. Okay. So anyway, thank you so much. And enjoy your evening in California while we have winter here. And to the audience, thank you again for participating, and to our residents for acting as the conduit for questioning. So I'll say good night and goodbye.
Thank you. Good night, everybody.